Hello and welcome to the Health Dialogue Show. I'm Yakshi, and in today's panel discussion, in observance of World Tuberculosis Day, we'll be exploring how these recent advancements in genetics and healthcare are revolutionizing tuberculosis diagnosis and its treatment. So, today, our esteemed panel of doctors who have vast experience will share their expertise on tuberculosis symptoms, the importance of completed treatment, and how we can work to reduce the stigma surrounding this treatable disease. So, now let's dive into this essential conversation and examine the strategies that are shaping the future of tuberculosis care. We have today with us Dr. Sandeep Reddy and Dr. Gunisha Pasricha. Dr. Sandeep Reddy is a consultant in infectious disease and an assistant professor of internal medicine at MS Ramaiah Medical College and Hospital. He also serves as the clinical advisor for hospital infection control and also the antimicrobial stewardship program at the institution. Dr. Reddy also holds a Doctor of Medicine degree in internal medicine, a diploma in tropical medicine and hygiene, a Master of Science in tropical medicine and international health, and also a certificate in tropical medicine. And we also have today Gunisha Pasricha with us, who is currently serving as the principal scientist and infectious disease expert at MedGenome Labs. She is having nearly 2 decades of experience in the biotechnology industry. She's a seasoned research and development manager with a strong track record. And she also holds a PhD in biotechnology from the Birla Institute of Technology and Sciences.
Thank you for having us, Yakshi. Thank
We
you.
welcome you.
It's always an interesting panel when you have both a clinician and a microbiologist and a scientist.
Yes,
So that completes the whole cycle as such. So thank you for the invite.
no issues, sir. We are privileged to have you both on board with us. So, sir, my first question is to you that can you please tell us what are some common symptoms of tuberculosis, that individuals should be aware of for early detection? And also how can we encourage people to seek treatment sooner?
Yeah, tuberculosis is one of my favorite bacteria out there. A good oxygen-loving bacteria. It loves the lungs predominantly. Transmission is by air droplets transmission from one person to another. And now, since it loves the oxygen, wants to thrive in an oxygen-rich environment. So one of the most common symptoms that one can perceive is the cough lasting anything more than 2 weeks. So in a high prevalent country like ours, very high endemic, so any patient that walks into any of the physicians, surgeons, or even a general GP with any chronic cough, that is cough more than 2 weeks, with associated symptoms of these constitutional, what we call as low appetite, unintentional weight loss, night sweats, predominantly a very specific symptom for TB, with a prolonged fever, unexplained, without any response to any multiple antibiotics, one starts thinking of whether am I dealing with a tuberculosis in him. Tuberculosis, on the other hand, also has a high migration to other organs. It loves the brain, the eyes, the bones, our gut, our genitourinary symptoms, the spine. So just not about cough, which is again probably a myth or a misnomer. Whenever I had a patient, the recent, who had low backache for quite a bit, 2 to 3 months. And when I asked him about the discussions when it went about TB, and he was like, no, doctor, I don't have any cough. So it's just a common myth among the public that TB and cough, and that's all it is about. So that's the myth that one needs to break, that tuberculosis can also present with other systemic manifestations. So any prolonged illness, unexplained, with constitutional symptoms of weight loss and the night sweats and the low-grade fever, and specifically working in an environment which predisposes them to exposure to tuberculosis. So you need to keep that in mind. Your differential diagnosis to be high for tuberculosis. Now, for the second part of your question, how do I encourage people? So it all comes down to the stigma for tuberculosis. Now we have kind of 2 types of a stigma. One is an established stigma where the patient experiences these unusual behavior from his family members or community when they get to know that this patient has tuberculosis. But the other stigma, which answers to your question, is the anticipated stigma. So any patient who thinks that he or she might have tuberculosis would not want to seek healthcare facilities because of fear that they might turn out to be positive for TB, and then what will the community think about them? What will their workplace think about them? Will they lose the work? Will the family kind of castrate them out from their homes? So it is the anticipated stigma that becomes a major hurdle for our patients for that health-seeking behavior when they have these symptoms which might uh, be tuberculosis. The second is always when it comes to the healthcare staff. So we need the regular, your general physicians, your family physicians, and your other alternative and complementary therapies that are Ayush doctors who prescribe, who kind of practice, because these are the patients who go to them. They do not land up with an IND specialist or get treated at the labs which Dr. Gunisha works for. It's the people, the low socioeconomic status people would go to these Ayush workers there who are very accessible to such cohort of population. So such healthcare workers need to be educated about and being made aware about this high prevalent state, and to kind of pick up these subtle symptoms and start for testing rather than treating with multiple antibiotics. So it is about the community engagement, the public education, as well as the healthcare awareness and access to investigations becomes much more important.
Okay, sir. Thank you so much. So, my next question is to you, ma'am. Can you tell us like what is actually genetic testing, and how has genetic testing actually changed the landscape of tuberculosis diagnosis?
Right. Yeah. Um, so genetic testing is nothing but it's just a medical test where you actually examine the DNA or RNA of a particular patient or of individual, and to either look for an infectious disease agent, or you're looking at a mutations which has happened, a change which has happened in the DNA and RNA which is related to a particular disease. So there are numerous genetic testing which are available, and what we're talking about, the diagnostic testing in context for TB. So I would say I think genetic testing has revolutionized TB detection, especially from the time TrueNat and the CBNat test, PCR based tests, which have come and which have been endorsed by WHO and also the NETP, the organization body which takes care of elimination of tuberculosis. It has revolutionized. Earlier it was traditionally done using a microscope and smear, which the sensitivity and picking up the bacteria was very less, as low as 30%. And from the time this has been integrated into the program for detection, the reporting of TB has exponentially increased. I think way back from 2011 has been into the system, and it has done tremendous work. Recently, I was there this week in the India TB Innovation program, which happened, which is a Government of India program, which was there, and there were 350 innovators, and we're providing all this innovation, especially for TB detection. And I think there are great times to come, especially when there's so much innovation happening in genetic testing. It's sooner or later those innovations will be integrated into the program. I just talked about the PCR test, that is polymerase chain, where you multiply the DNA multiple times to actually detect the organism. And there are also other variety of tests like sequencing based test or a next generation sequencing based test. That is the way forward, and that's what I understand, and what MedGenome is also aligning to the same thought, that the newer, better genetic tests also have to be integrated.
Thank you so much.
If I may just add to Dr.
Yes,
Gunisha.
sir, of course. Of course, sir.
Yeah, so Yakshi, you need to understand that previously, probably in the 1990s and the early 2000s, we were very dependent on sputum, under the sputum, and then seeing under the microscope And for that, and all the staining methods, and then you would know whether your patient would have tuberculosis or not. The main thing, you need a trained person looking in those microscopes. It is just not that
Yeah.
anyone would come, do the staining, and report. So you need a trained person, and getting a personnel to be trained, to be at every facility, starting from a rural to a urban, was the major difficulty that we used to face. So there were a lot of cases that were missed about. And what molecular genetics, the just trying to using the DNA and the RNA for majority of our diseases has done, is what we call as this a point of care testing. So you just
Mm.
like, it's almost similar to your UPT, urinary pregnancy test, for public, that if I want to compare to. So it's just a UPT kind of a test where you just need to point of care, cartridge based. You don't need a trained personalized to tell you whether it is a positive or negative. So,
Yeah.
and the cost of all these technology has come drastically down, where
Mm.
any facility with just a little bit of an investment can have, with a small place, get these point of care testing done. And the time to turnaround times, the TATs, what we call, has come drastically down. Previously, the gram stain, it needs to be stained. We got to have to wait for 1 day for the reports to come. But these point of care genetic testing has revolutionized and decreased the TATs to about 2 to 3 hours. So before the patient could walk out of your cabin, you would know definitely whether your patient has got tuberculosis or not. So
Yeah.
testing has revolutionized the way we practice, and I think that's the major basis for our goal to end TB in the next few years, decades to come. So it is hats off to people like Dr. Gunisha and their teams, that we've achieved what we've achieved until now.
Yeah,
That's
thank
true,
you,
sir.
Dr. Sandeep, for adding on to what I said.
And
Yes.
one more thing, as ma'am mentioned about the TB innovations that just happened. Now it was the sputum that you need to, the patient has to really cough out to get the testing done. I think there is a team that's looking at just the saliva, just
Right.
using a swabbing with just the saliva. The point of care testing would pick it up, and it becomes so easier. Just swab
Right.
the, like how just the saliva in the oral cavity, and you'd know TB or not. So
Yeah.
innovation, as ma'am mentioned, is leaping bound. So I'm very optimistic that we would achieve the NTB of our country, given the resources and the talent that we've got in our place.
Thank you so much, sir, for adding this. There's a question for you
Mhm.
that what strategies can be implemented, like in an awareness campaign, for to combat the stigma surrounding tuberculosis?
Yeah, so for that, I would want to kind of divide into the cohort of population that I need to start looking at the awareness. If I want to take is the public, so community awareness, your public educations, so going through your media, getting your celebrities to speak about tuberculosis, destigmatizing the whole concept of TB. Now, until now, the what we call the narrative was all about the disease. Now we've got to move from a disease centric to a patient centric. So trying to use survivor stories, like how the whole mental health just took off a huge kind of a curve when Deepika Padukone and other celebrities started speaking about how mental health is important, while our cricketers started taking time off from their sport, just telling that they need space for the mental space. So, and hence the whole mental health giving importance to it just leap bounded. In similar way, once we start destigmatizing using such celebrities, such high influencers, uh, people will then start seeking that behavior, thinking that TB is not so harmful as what it was. Previously, yes, our old movies, if you go to Raj Kapoor movies, I think there are two movies where one of the lead actor gets TB and he goes to one guest house in Shimla and trying to spend his days off in the fresh air, and that's how the end of life is. But now we've moved on to a curative kind of an approach. TB can be cured, and that message needs to go loud and clear out into the public. So community engagement using our religious leaders, because that makes important part there, using our celebrities, influencers, our government organizations, and other non-governmental organizations, speaking loud and clear into the communities. When it comes to patient per se, yes, removing the destigmatizing both the established stigma where they get their behaviors, where they've gone through, experienced those untruly behaviors, or the anticipated stigma. We got to remove it. This is where I usually do at our hospitals what we call it as a buddy system. So
Yeah.
my new tuberculosis patient gets linked with my old TB patient who is either on treatment, end of the tunnel, or who's already cured and doing well. So I've got a link between them, again with both consents from both the parties, where they talk to each other. So just talking from a doctor, the patient would be like, okay, the doctor tells all the stuff, but he'll never experience what I'm going through, what the stigma I'm going through. Is just sitting in a 4x4 room and talks about all such things, but unless he experiences, he wouldn't know what I'm going through. So those are the narratives that I get to hear. So what we started was a buddy system. So my old tuberculosis patient who's still in touch with us, who comes for a regular follow-up, will get connected to such new TB patients who come and speak to him. So once you have a cured patient, we always have that proverb saying, old patient is better than a new doctor. So I get that old patient, come and speak to the new patients, give them the hope that to go through that phase, to complete the treatment, and that you'll all be all right. So that encourages my patient to be compliant with their medications despite the adverse events, despite the stigma. They stick to it. There'll be regular follow-ups with us, and one day they become a buddy to another new TB patient. So that chain is being formed at my institution. So that makes a major impact. And the third one is the healthcare population, that the healthcare team that we kind of give awareness through regular CME. I mean, every time NTP or the WHO comes with an update, we make sure we hold a small meeting among my pulmonologists, my internal medicine physicians, my emergency medicine physicians, my geriatric teams, to kind of talk about what's the new updates, what are the new diagnostic tests out there, and other CME awareness programs. So educating the public, the patient, destigmatizing there, and then empowering my healthcare professionals with all the point of care diagnostic tests and updates on the next, what are the new rules, guidelines, and new treatment options. So 3 in 3, that's how we try to do our bit for that program.
That's great, sir. Great ideas. So, Dr. Gunisha, ma'am, there's a question for you. Like, what is the role of genetic testing and drug-resistant testing?
Right. So I mentioned about the tests, the PCR-based test,
Yeah.
a test like a TrueNat test, which is basically it'll tell you, you have TB or not, which is a point of care test, like Dr. Sandeep mentioned, which is available at primary health centers and all of that. But however, the drug resistance testing is a coverage basis where it does detection and also gives you, it tells you about resistance of the first line drugs which is used, which is called CBNAT or a gene expert test. So drug resistance testing is very, very important in India, especially the burden of drug resistance patients which we have in India is immense, like close to 27 to 28% of all the patients of global drug resistant patient are in India. So it becomes very, very, very important. So yes, to answer the question, PCR based tests like a CBNAT test are available, which has they've again revolutionized testing and decreased the time of test, the time it takes. So just to tell you, the traditional drug resistant tests are those phenotypic drug resistant tests, which which are culture based. Basically, you put the sputum sample or any other sample apart from sputum, like extrapulmonary, like a CSF, or any other sample, grow it. And this tuberculosis bacteria is a slow growing bacteria. It'll take its own time to grow. If you're growing on a solid media, it would take you 6 weeks to grow, but there is some happenings there where now in 4 to 5 weeks you can it grows. So it's such a slow growing bacteria. It takes 4 to 5 weeks, and if you want to do drug resistant testing again, it will take another 2 3 weeks. So by the time the patient actually knows that you have a drug resistant TB, it will be like more than 6 to 8, or sometimes in some cases 10 weeks. That is a deterrent, though it is a gold standard for drug resistant testing. There is a lot of work which is happening, like a CBNAT test. However, it will just tell you, first line drugs, the drug resistance is there or not. There are other tests like a line probe assays, which have been also added into a program which detects resistance to the first line as well as the second line drugs. It is again a molecular test, another genetic test, but it does not give you a complete picture, because
Yeah.
actually WHO has endorsed a bit of like 18 drugs. Probably Dr. Sandeep will know better on that. 18 drugs which can be used as a drug regime based on the condition, and so on and so forth. So what is needed? So I mentioned it, there has been revolution with LPA test and also the gene export or CBNAT test, but something more is needed. We have reached a point where we need more than that. We need to get drug resistant information for the newer drugs, especially in terms, we're talking about the multi drug resistance. So there are multi drug resistance TB patients who are resistant to the first line drugs, rifampicin and isoniazid, and there is something called pre-XDR or XDR, where there is to the second line and also to the newer drugs, the drug resistance. So considering the load of bacterial resistant or a MDR or XDR patient in India, we also have to move from these already endorsed tests by WHO or NTP and go to something like a next generation sequencing, where a whole genome sequencing can be done directly from clinical time. You save all that time which I mentioned. It's going to take you 6 to 8, 10 weeks. By the time that patient has coughed up more and
Yeah.
transmitted multi-drug resistant infection to other patients. So the key is diagnosing them fast. Like diagnosis can be done in few hours, and all of that is available in the primary health center, but also detecting drug resistant quickly becomes very, very important. So something there are tests available, and I could also add, we also have a test which can give you in 6 to 8 days the drug resistance pattern for all 20 drugs which are available in the market. There is something, again, I think the molecular based tests are the key, and the public private partnership which needs to be done to integrate all of this into the program becomes important.
Thank you so much, ma'am. So, Dr. Sandeep, can you please tell us that what are the factors contributing to the rise of drug-resistant tuberculosis, and how can we normally address it?
So, for the non-medical who would be listening to this webinar, is now tuberculosis is another very stubborn bacteria, very
Yes.
resistant to antibiotics. So, if you would want to compare all your regular bacteria of cold, diarrhea, skin and soft infections, you'd require 1 or 2 antibiotics to get over with it with a short span of period. But tuberculosis, being a very stubborn, has got a nice little coat around it, which does not allow your regular antibiotics to penetrate it and to kill it. It forms a nice little fortress when it lodges into the lungs, the brain, wherever it is bones. So there is difficulty of your regular antibiotics to penetrate that fort. It builds a really good fort around it. So what during the ages that trials and combinations we've come, we came to a conclusion of using 4 antibiotics of different classes, different types of an action to break that fort and to get that cure what we were hoping for. Now, over the years, the TB evolution, the bacteria evolution, what it's caused is the drug resistant, meaning you're multi-drug resistant. The word suggests that the four antibiotics that we were using, mainly with the isoniazid and the rifampicin, so now the tuberculosis bacteria would be resistant to either one or both of them. So that makes it an multi-drug resistant. And ma'am kind of dropped a word called XDR and a PDR. So extreme drug resistant would be almost all the first four first line of drugs, and then a few second line of drugs that we had would be an extreme drug resistant. And then the PDR is the pan drug resistant. That means like a pan India movie release. So here every antibiotic would be resistant. So the drug is the the bug would be the super bug of bacteria, and then any antibiotic you would give will not work. Now, why did we land up in such a situation? So, as you mentioned, who are my high risk population? So, my high risk population are those, the first ones would be those tuberculosis patients who were drug sensitive TB patients who, for varied reasons, stopped their treatment in between, which is a 6 months, usually a 6 month kind of a treatment regimen marathon that we run with the patient. Whether it is a stigma, financial compliance, other comorbid conditions, severe side effects to the drug, or trying alternative and complementary therapy based on media, peer pressures. Someone said, go to this tribal village and try out these leaves and stems and barks. So, due to varied reasons, once they stop their usual first line drugs, the TB bacilli, which is still there, hovering around, will then change their genetic evolution to become drug resistant. The second one is the set of patients who are immunosuppressed, who are immunocompromised. Whether it is my patient living with HIV, or my cancer care chemotherapeutic patients, or patients who are on steroids, intravenous drug abusers. So any or immunosuppressed patient can get this drug resistant tuberculosis bacilli very easily. Because this drug resistant TB is highly transmissible, so your environments like in prison, that's where South Africa had a lot of issues where there was huge kind of a burden where a lot of prisoners, the density of the inmates was higher, overburdened those prisons. So there the transmission was higher, and HIV being also a very huge burden in South Africa. So they started seeing a lot of drug resistant TB. Even in our country, our prisons capacity has been overloaded. So there our drug resistant transmission is high. And then in our low socioeconomic status, where in a small little 4x4 kind of a house, you have got 20 people living in with all sorts of poor hygienic conditions. So there the transmission goes higher. So things like these, conditions like these, when a patient comes to us, and if TB is in high in our index of suspicion, we start thinking about, am I dealing with a drug resistant TB? The other factor which has influenced the drug resistance TB is the use of over-the-counter antibiotics. So because many of the medications, as ma'am mentioned, we've got about 20 different types of antibiotics to treat TB. Now, because we are highly prevalent and highly endemic, we would have what we call as a latent TB, meaning the TB bacilli is there within us, but it's still not showed any symptoms. So and we'll never know until we test it for it. There are a few point of care genetic testing for that. So such patients, for every simple cold, cough, and in the last 2 months, I'm sure with the viral sore throat, but we would have taken a lot of azithromycins, clarithromycins, amoxicillins. These are medications that we give for TB patients as a second line management. Now, constant and recurrent use of these over-the-counter medications, antibiotics, would then you exposing these small doses of antibiotics, incomplete courses of antibiotics to the TB bacilli, and whatever it was latent, and it will be drug sensitive, but because of our behavior, we would have turned it into a drug resistant TB, and then it finds its time to showcase its effect. So over-the-counter drugs, stigma, and then such environments in high-risk individuals are the factors that we see a rise in the drug-resistant tuberculosis infections. how do we kind of overcome these hurdles is at the time of testing. As ma'am mentioned, we have point of care tests now to detect our MDRs. But the problem is, it is mainly available in probably tier 1 and tier 2 cities, where the rural still are still dealing with the gram stains and things. So the government should come up and should kind of make it available across all tiers of health system. For the XDRs and TDRs, it might not be available even in Ramaiah. We send it to centers of excellence, where the government has recognized few centers where we look at the whole drug sensitivity pattern at these centers. So, trying to be for my healthcare professional to be aware of such centers where to send for testing. That's one thing. The second thing is where we are integrating TB screening in when a patient would come for their annual health checkup. So this is how we are trying to pick are these latent tuberculosis who's not been symptomatic. So they come there for the regular annual health checkup, or they come for their surgical pre workup. Where if we feel that this patient belongs to these high risk individuals, we would screen them for tuberculosis. So all my HIV patients would come for HIV treatment, whether they have symptoms or not, we would screen for them. All my patients who've been diagnosed with cancer would want to go on those cancer chemotherapeutics, on other rheumatological conditions, they get screened for TB. So trying to pick my high risk populations, even though they've not come specially for TB, we tried to screen for them. That's about it. And contact tracing is one thing that we do, meaning if I get a TB patient, we trace every patient that every person that he's come in contact with and try to screen them for TB. So trying to pick up these cases early before they become full blown and they transmit to another. So we are cutting the chain of transmission as soon as possible. And during the treatment for these XDR TBs and the MDR TBs, previously, as ma'am mentioned, there were about 8 to 10 medications that we had to give, and few of them were injections for about 18 months. So it was literally hell that they go through. I probably, if I was in place, even as a doctor, I would say I would have given up. Taking injections every other day for 18 months is just not so easy. But we've come a long way. Now we've shortened the course. It's just oral tablets, medications for about 6 months, and we could be cured of MDR. So during now the treatment regimen is shortened from injectables. We've come to oral drugs, and government has made an amazing initiative where they've not released these the newer medications into the public for the scared of again using over the counter, for being concerned that your regular GPs and the family physicians would use it left and right. So it's only available in these center of excellences. Not even my institution, not even ID specialists like this gets our hands on such medication. We need to send my patient to the center of excellence where they're given me drug under caution and authorization. So trying to contain and trying to carefully safeguard these second line medications, oral tablets has been going through. And post treatment, because trying to at the end of the treatment, we are making sure that they're cured. We are using whether it is the imaging, CT scans, the point of care genetic testing, repeating the sputum test. We are making sure that they're being cured, that there's no chance of further transmission. And then regular follow-ups at 3, 6, 9 months until 2 years. We make sure all my MDR, XDR patients go up to 2 years of follow-up. They're all healthy and there's no risk of relapse or recurrence. So prior to diagnosis, during the treatments, and post even end of treatment, we make sure the continuity of care and follow-up is established so that the transmission is cut short and the prevalence is on the decline. So this is how we do on a clinical side.
Thank you so much, sir, for sharing this with us today. So, ma'am, my last question is to you that with the advancements in genetic screening for tuberculosis, how can we ensure that these tools are actually accessible for the underserved populations?
Right, absolutely. A great question, actually. That is, I think, the most important part where all this testing, though available, has to reach the rural areas, it has to reach the primary health care centers. It's very, very important. So fortunately, yes, the TrueNAT test, which is, just they are battery operated PCR based tests, those are accessible now, which have changed and increased the detection of TB. But again, their reach is still limited. I think that it has been in the government sector, all of this, making it available. So I think again, a public-private partnership here would really help the government to help all these people, because what I understand, like how Dr. Sandeep mentioned, many of the 50% of the patients actually do not go to the government sector; they also come in the private sectors. But in any case, we are talking about reachability in the rural areas. So I think such tests are already available. More innovation is happening. There are tests, as Dr. Sandeep mentioned, from directly from saliva. I mean, very small devices where you don't even need battery, or even smaller, cheaper, rapid tests. So those are the keys to actually reach out to the rural areas. And also testing in those mobile vans, because sometimes they can't even reach the primary healthcare centers. So and having those, I understand all of this is happening at some scale, but I think it has to happen at larger scale, where the testing could be done in those mobile vans. And apart from just these testing, even those AI enabled X-ray viewing and diagnosing this before any test is done, that is also a fantastic innovation which has happened, and which can be integrated in just mobile van. And I think the connectivity which we have across the data internet, that has to be harnessed for the reachability. It is there, but if we've unfortunately not met the 2025 goal, but in case we want to meet the WHO goal, which is of 2030, I think all this integration and at larger scale, I mean, whatever is happening, probably 100-fold scale, we have to do it. Subsidize the cost. I think NETP should do that, subsidize the cost, and again, engage in more partnership and more innovation. And I think hopefully by 2030 we can eliminate or close to eliminating TB from India.
Definitely, ma'am, definitely. So, thank you so much, Dr. Gunisha and Dr. Sandeep, for sharing your expertise and thoughtful contributions with us today. Like, we are really grateful for your time and valuable input in this important discussion. Thank you so much.
Thank you, actually. Thank you, Dr. Sandeep.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.